Okay, great. Okay, so good evening, everyone. So I'm going to be talking about ocular surface surgical repair. These are my disclosures. They don't really relate to the subject of the talk. So when considering the ocular surface or ocular surface surgery, I think it's important to really look at the whole ocular surface as one unit. So of course, we must consider the lids in any part of surgery that we do on the cornea, as well as the conjunctiva, and of course the corneal epithelial surface itself. And I think that if we do not look at the other parts of the ocular surface and just focus on the cornea, then it's going to be detrimental on our outcomes, and you've heard this from the previous speakers as well. Now it's important, it's very difficult in 10 minutes to talk about all this kind of surgery, but we know from lots of studies that it's important to repair any malposition of the lid, either with ectropion, entropion or torsography surgery, or even buccal mucosal grafts in patients with severe Stevens-Johnson syndrome, because this will help improve the ocular surface. You've heard a lot of speakers talk about improvements in tear film with lubricants, anti-inflammatory medication and plugs, and likewise, obviously, proscleral contact lenses are a very good way of actually avoiding patients undergoing surgery itself. When we consider the surgery themselves, though, there are basically three things to basically look at. One, as Barry basically mentioned, is the state of the conjunctiva, where it's normal, abnormal, or it's scarred, whether the scarring is localized or it's non-localized, whether or not you have to use adjunctive agents such as mitomycin C or cryotherapy, and I'll show you some examples of that. And of course, it is important to look at the state of the flora itself, because you may have to alter your oral immunosuppression. I'll show you some examples of where we basically do that. The key thing really is assessing the conjunctiva, I think, to start off with. Of course, conjunctiva forms a majority of the ocular surface. If you have a nice healthy conjunctiva like this, of course it allows you to do a lot with the conjunctiva during your surgery. If your conjunctiva is scarred like this as well, any basically irritation can incite inflammation in this situation, and of course it's going to affect your surgical outcome. So let me just show you some examples, first of all, in a normal conjunctiva where you can help this to do your ocular surface. So here you'll see a patient of mine undergoing sutureless Gunderson flap surgery, and on the right, double head pterygium surgery itself. So we have a lot of pterygium surgery in Singapore because, of course, we live quite close to the equator. Now, both of these surgical procedures are doable because the conjunctiva is essentially normal. So you can basically move the conjunctiva in this situation over the corneal surface quite easily once you basically get a nice plane underneath basically the conjunctival epithelium itself. And here you'll see basically I'm debriding this superior and then basically the inferior part of the epithelium, doing a porotomy, and then we'll basically bring this down and use fibrin glue to glue this basically onto the surface. Here with the double head pterygium, we use a technique where often we'll use one large pterygium graft and we'll split this basically into two and then put one on either side of the double heads and then basically glue this into position for both sides. But this is only doable because the conjunctiva is essentially healthy, there's no scarring, and you can mobilize the conjunctiva quite easily and then glue this in position. Once it's basically glued, of course, this will basically stay into place, and then it allows you to basically adhere the edges, because you can advance the conjunctiva on either side to minimize your defects, to allow you to use one piece of conjunctiva into both sides of the graft. If you look at the outcomes basically from doing Gunderson flap surgery, over here, this is a series we published a few years back now itself. You'll see that you can get very good outcomes by using the flapless, using fibrin glue. Patients don't get so much pain in the postoperative outcome, and sometimes you can advance it from the superior side as well as the inferior sides, like in this example over here itself. And with time, you'll see the vascularization will basically thin out, and you'll get quite a good cosmetic outcome as well. And you can often put a contact lens on the surface as well if you want to improve the cosmesis. When you look at double head pterygia, this is the same patient here. This is immediately post-op. This is basically 6 months post-op itself, and you can see good adhesion on the surface. But essentially, this works because the conjunctiva is basically healthy. If you look at the options for basically surgical treatment with double head pterygia, you'll see there are a lot of options reported in the literature. Some will basically remove one side and put a conjunctival autograft and leave a bare sclera on the other side. Some have described primary closure, even though this doesn't really look that good. And of course, these are associated with increased risk of recurrence. You can use a sliding conjunctival graft, and I've done this before, but it doesn't actually look cosmetically quite good. Of course, you can put AMT on one side and conjunctival on the other side, or a rotational autograft where you take the pterygium off and you rotate it around and basically remove the fibrovascular tissue from underneath itself. The others basically will use a combination of techniques where you split a conjunctival autograft, or you put an AMT skirt around the conjunctival autograft to basically reduce the fibrosis. From our series of about 61 cases that we looked at a few years back, we had about 5 cases of recurrence. Of course, this will be higher than in your primary series. And generally, they did all quite well with basically gluing. We didn't use any mitomycin C at all in these double head pterygiums. You do have to be careful, though, like in this example over here, with one of my patients who basically had a flare-up of a herpes simplex following her pterygium surgery with stromal necrosis that required oral steroids to get rid of the inflammatory response, even from basically undergoing pterygium surgery. Now, in cases where the conjunctiva is locally fibrosed, as you can see in this example on this side with a patient with CIN, or in this side with localized granuloma, this patient had beta irradiation therapy done to basically treat their primary pterygium. You can see this huge pyogenic granuloma. You're going to get a lot of inflammation and scarring on the surface. Likewise, patients with tumors like this on the ocular surface over here itself, you need to find a plane underneath the tumor, but this will also go onto the conjunctiva itself. But you're going to have to use some adjuvants along with your standard ocular surface surgery to repair the surface. In this situation over here, I'll use a low dose of mitomycin C to put underneath the conjunctiva to help with the fibrosis. Here you will see that once I remove the tumor area with a wide resection of the conjunctiva, I'll use cryotherapy to the base over here. I'm just orientating the tumor here before we send it to pathology, and here we'll use a combination of cryotherapy before I will basically close this up with a conjunctival graft. Again, you go to an area of normal conjunctiva. It's the same technique for removing the conjunctiva, and then we'll glue this basically into place over our defect of our tumor. How does this look like in the long term? So this is the same patient. You'll see in the immediate post-operative period over here. At this time, it's quite old now. This is about 5 years post-op. You'll see he's got quite a good result over here. Essentially, you can't see the area of fibrosis where we basically remove the tumor. It's important to do a wide resection, and then often I'll put a suture into the tumor itself before I send it to pathology, so the pathology can make sure that we basically remove the tumor from the wide resection. You can see over here, this was CIN. You can see the migration into the basal epithelium. This is the patient with the granuloma. This is obviously pre-op. This is immediately post-op, and this is basically after 5 years post-op. And often you will see this area of telangiectasia in patients that have had beta radiation, and this is a consequence of the beta radiation. But you can see there's no evidence of any recurrence. Now, if you don't have any abnormal conjunctiva, of course, you cannot advance a conjunctiva. So this is a patient over here with a chemical injury. So here we're putting a cryo-preserved AMT graft. And as Barry basically showed you, we also have amniotech, which is a freeze-dried amniotic membrane. The advantage of this is that you can do this in the clinic. This is just on the slit lamp. And you can simply basically put this on the surface, put a speculum in the patient's eye, and basically apply the AMT over the surface. Banded contact lens goes on the surface. Of course, with the cryo-preserved amniotic membrane, this has to be done in OT. It's important to know that there is a difference between the cryopreserved amniotic membrane and the freeze-dried amniotic membrane. This is a histology section showing you the difference. This is cryopreserved on this side. This is freeze-dried on this side over here itself. A few years back, we did a whole array of immunological testings. If you essentially look at the ECM matrix testing over here, it's a bit easy to look at this figure on this side over here. You'll see essentially most of the ECM matrix is preserved in the dehydrated amniotic membrane compared to the cryopreserved. However, if you start looking at the growth factors, you look at the growth factor levels are vastly reduced in the processing of the freeze-dried amniotic membrane compared to that of cryopreserved. So if you're using your membrane as an anti-inflammatory component, you should use cryopreserved. If you wanted to use it as a scaffold to grow, as you can see over here on the SEM and the AFM, then you can consider using freeze-dried amniotic membrane. There's also another difference between the membranes, of course. When you harvest cryopreserved membrane, where it's basically harvested from the amniotic sac in relation to placenta will affect the light transmission. If it's harvested close to the placenta over here, you can see in this curve over here, the light transmission is very poor. Those that are further away are much, much more clearer with respect to light transmission. So you get a much thinner area because you get much less stroma on your amniotic graft itself. And you can see this is the equivalent line of freeze-dried amniotic membrane, which is very similar to what you will basically see in distal harvested cryopreserved amniotic membrane tissue. This is just a patient from the same paper, so you can see this is pre-op, very unstable epithelium. This is after we've onlayed the cryopreserved amniotic membrane, showing the epithelial defect, and this is following epithelial migration by 17 days, and it's basically healed and stabilized the surface. However, in more severe ocular surface damage, of course, we're going to basically look on the corneal epithelium. Here is a patient of Stevens-Johnson syndrome. You can see quite bad scarring. This is his only eye. His other eye has already been lost from severe Stevens-Johnson and limbal stem cell deficiency and a thiastical eye. And he presented to me like this initially. He then basically disappeared and then basically represented over here. And you can see a small dismissive seal on the surface. And basically following his first dog surgery that we did on this eye itself, he had very poor ocular surface healing. You can see this thinning and necrosis in the inferior part of the cornea. So we went back to OT, and as we talked about in the earlier session with dog, obviously one of the advantages of dog surgery is that you can redo the dog But when we came to basically take him back to OT, if you look at this area very closely over here, by the time he came back to OT after he DNA'd a few appointments, he actually had a very, very small perforation in his previous dog surgery over here itself. And you can see how injected his eye is as well. He's not a very compliant patient to taking long-term medication. So, of course, we go back to remove the previous tissue. Again, went to the area of previous perforation at the end. Once we basically removed all the necrotic stromal tissue, then finally go back to the area of perforation, and using a combination of air in the anterior chamber, you can try to maintain an anterior chamber to allow you to perform the surgery itself. So I managed to remove the previous dog tissue and try to remove some of the stromal necrosis from do a stromectomy around the area of the stromal tissue. Then put the new dog tissue in, remove the previous dog tissue, and under an air tamponade inside the anterior chamber, suture on basically your new graft itself, and then keep an air tamponade in to try to put up the new membrane, even though he has a small hole on this side. How did he look post-operatively? So this is what he was like after his initial surgery. You see epithelial defect. This is basically what he was like post-operatively after his repeat dog surgery. He then went away and came back about 4 months later with this. So he had an infection basically on his surface of his new dog. So after I shouted at him and took some scrapes on the surface itself, I managed to resolve his infection. But he provided a very good lesson because the inflammation now has calmed down over here, and I switched him on to oral mycophenolate. And if you look, these are all the bugs that we've grown from his surface over the last 2.5 years itself. And one of the things about Stevens-Johnson syndrome patients is that they too get this chronic relapsing kind of infection, and it is related to the flora on the ocular surface. So even though now he's immunosuppressed, we regularly do surface conjunctival swabs. He has a contact lens on the surface. I send that for histology. I send it for culture every 4 months, and we keep on rotating his antibiotics to keep on changing his ocular surface flora because often they're basically immunosuppressed. Of course, in very severe disease where you'll need to basically think about limbal stem cell reconstruction, you have two options. One is using ex vivo expansion, as Paolo Rama basically described, and Professor Kanashida's group have been pioneers on using oral mucosa. So in summary, in conclusion, surgical ocular surface reconstruction must include assessment of the whole ocular surface tissue. This includes the lids, the tear film, the conjunctiva, as well as the cornea itself. Conjunctival surgery will be dependent on the degree of conjunctival fibrosis, which must be assessed clinically. The use of adjuvants such as mitomycin C and cryotherapy is useful in complex cases. New products such as irradiated amniotic membrane allow for it to be a chair procedure. We do this in clinic all the time to help with the epithelial healing. And in chronic inflammation, it is vital to assess the abnormal flora because it's important that this is an ongoing inducement of inflammation. Thank you for your attention.